You all semua dah ready dah?
Belum lagi, Doktor.
Oh, dah siap semua tadi dah? Ha? Okey, dah. Semua ada dah?
Belum lagi doktor, tapi
Siapa berapa orang tak ada lagi?
tiga, but I think some of them have internet problem kot. Because we are in quarantine.
Quarantine?
So,
Kenapa?
so semua pakai data. Sebab baru masuk UIA. Sebab dah masuk UIA. Sebab we have to go for quarantine first. So semua orang pakai data masing-masing.
Oh, bukannya tu. So bila you quarantine?
Today is day, tak tahu lah, maybe day 5 or day 6. Yeah. So
Monday?
we have to quarantine for 10 days. Yeah, we came last Monday.
Oh, so pakai internet data sendiri? Buat yang tak boleh pakai yang itu punya? College punya memang tak clear? Tak tahu?
Yeah, the Wi-Fi macam, no, dia tak strong. Yeah.
College punya tak strong?
Tak.
Kenapa tak tahu?
Tak sure doktor.
Dari dulu lagi?
Hmm?
Dari dulu lagi?
Maybe in this particular mahalah kot, sebab this is the old mahalah yang kita pakai untuk quarantine ni. Yeah.
Mahalah baru okey Wi-Fi dia?
Okay.
Mahalah lama tu? Dia akan, kalau hari weekend, weekday pun sama juga?
Sama juga, ya.
Sebab bila you all punya akan continue, you all akan habis?
This coming Thursday kot, insyaAllah. Thursday ni boleh keluar kan? Ya.
Year berapa you all ni?
Year 3.
Oh, ada teaching lagi kan? Ada respiratory teaching semua tu ada tu?
Minggu depan semua seminar.
Seminar semua, macam mana you nak buat kalau some of you not good dalam ni? Berapa ramai yang tak dapat lagi masuk tu?
Ada dalam 3.
Kenapa dia orang tak boleh share tu? Duduk you all tak boleh share sama you all?
Tak sure doktor.
You all pakai handphone ke komputer? Ada pakai handphone, ada pakai komputer?
Saya pakai komputer.
Ada pakai handphone?
Ada yang pakai phone juga kot.
Kita tengok sampai ni, kasih lagi 5 minit. Give 5 minutes more
Doctor, are you there?
Dah. Yang tu dapat dah hidup orang dah. Tak dapat juga.
Tak dapat nak kontak yang lain tu. So yang belum masuk kelas ni tak dapat nak kontak dia orang. Tapi this session is recorded lah. So maybe they can watch the recorded session. We already tried contacting tapi tak dapat.
Kenapa handphone orang tak jawab?
Tak.
You tak boleh keluar kan?
Tak boleh.
Semua duduk dalam bilik kan? Dan makan semua macam mana?
Diorang provide makanan.
Boring je. Sedap ke makan orang?
Most of the time sedap lah tak? Most of the time sedap lah. Tapi
dia beri menu ke ataupun you boleh dia hantar apa yang suka hati diorang ya?
Diorang yang hantar ikut suka hati. Rasanya diorang dah ada list menu untuk kita orang makan.
Ya. Siapa yang masak luar ke atau masak kat mana?
Masak dekat luar kot, macam tender. Saya rasa diorang ambil tender daripada kafe juga kot. Rasanya lah, tak tahu.
Apa you buat dalam tu? Tak ada buat apa lah.
Boleh buat TikTok je doktor.
Exercise semua tak ada?
Ada exercise.
Your exercise macam mana dalam bilik je lah. Turun naik angkat berat macam tu je. Berapa ramai?
Berapa ramai apa doktor?
Cuma year 3.
140 something.
Ya. Apalah nasib you all lah. Aku tak faham. Tempat lain buat assembly yang sama ke? Universiti lain?
Saya rasa macam tu kot, tak sure.
Ya. Tak apalah. Okay, talking today about respiratory examination. Last tu dah Monday hari tu kan, masa lecture pasal history taking tu, ada yang dapat, ada yang tak dapat lah. Tak tahu.
Maksud tu?
Yang history taking tu.
Dapat apa tu? Dapat apa yang doktor sampaikan?
Ada yang tak dapat. Apa tu tak dapat nak participate. Yang Monday petang dia lecture pasal history taking tu.
Oh, saya rasa yang tu semua ada kot.
Ya. Tak apalah. Okay, we start today. I okay je. Kalau yang nak tunggu sampai yang semua dapat boleh postpone waktu lain sebab sister sekarang ni buat 12 tengah malam pun boleh. Buat 2-3 pagi pun boleh sebab semua pakai komputer kan. Dulu sebab because you do at lecture hall, jadi dia kena specific time. Sekarang ni because the system as like this, you nak buat pukul 1 pagi, pukul apa? Lepas subuh, semua boleh buat. Gantung you all boleh bangun pagi tak? You bangun pagi tak? Soal subuh?
Bangun doktor, bangun.
Ya. Yelah tu. Okay, we talk on respiratory examination. Respiratory pathology, kalau you go into the ward, respiratory pathology is the main pathology why the child been admitted to the hospital, to the ward. Even when you are doing GP clinics as a junior practitioner or as a primary level, healthcare level, you will notice that respiratory complaint in children is the main complaint. It's something that there. So you have to well versed in examination on respiratory. Okay, you read the book, they must be like this, like that, like that. Tapi but from our experience, the main information you will get if you can make the child comfortable and cooperative. It doesn't matter how old the child is, doesn't matter. You'll be surprised that the key of to get the main information. Second, there is a lot involved in observation. Your eyes must be sharp. even sharper than an eagle, because a lot of information you can gather from observation only. Children, they have this stranger anxiety, and then nobody like to be touched by stranger, especially doctor, because the thought that doctor ni they related with somebody nak cucuk dia orang. So they always afraid of, because the culture is that. So children, when you doing physical examination, children, so when the patient come out into the room already, you already start scanning the child. That's the important thing now. And pediatrician, one thing about them, they're very observant. They're very observant because that is our bread and butter. So main function of respiratory system in children are the main one, breathing, gas exchange function. The other is some defense, metabolic, depositic, filtration, and so on. But mainly is we're talking about breathing and gas exchange function. And then there is the respiratory system. You can look, it started from the nasal cavity, even oral cavity. It goes down until the pharynx, larynx, and then the epiglottis, the trachea, and then the bronchial tree. And then the lung itself per se, and the pleural membranes, the diaphragms, and the muscle. So it's divided to upper and lower. If you want to know, the upper is anything that extra thoracic. You see insertion, you go to your inlet, thoracic inlet, you can touch at the upper end of medullary sterni, the upper, the insertion. So anything above it, including 1/3 of trachea, is considered as upper. Anything below it, 1/3 trachea, 2/3 trachea and below, considered as lower. That is the human respiratory system. So the upper, including the adenoid, thoracic, tonsils, epiglottis, larynx, and some up 1/3 of trachea. The lower include the 2/3 of trachea and the rest. I think you all know, you learned the anatomy before, the anatomy of respiratory system. Surface marking. So the lung per se, and then the pleural space. The right side of the lung got 3 lobes, divided by the horizontal fissure usually at the 4th ribs, and then the middle lobes, and then the oblique fissure. And then 2 intercostal space. They usually, if adult, many big children, 6 ribs, and then 2 ribs below 8 is the pleural space and pleural membrane. Whereas in the upper, and on the left side is 2 lobes only. There is no the horizontal lobe, but the middle lobe is replaced by the lingula. And then at the posterior, you can look at the posterior, mainly is either is right or left is upper lobe and middle lobe, upper lobe and lower lobe. Whereas in the anterior, it can be upper, middle, and lower for the right side of the lung. And then you can see here the upper lobe, and then the lower lobe, and then in the this is the, you can, as you can look here, the diaphragm, the surface marking. That's how you, important of this, and when you auscultate the lung, so you can see this anterior, there is the from the lateral, anterior and lateral. So the importance of this is that when you auscultate, you know which lobe do you auscultate. When you percuss, you know which lobe you are percuss. Though dalam examination, you divided the lung surface in terms of upper lobe, upper zone, mid zone, and lower zone, but in the back of your mind, what underlying it, you know which lobe you examine when you do the examination. You anteriorly, yeah, this is the how is it anteriorly, at the laterally something like this, and posteriorly is mainly the upper lobe. 1/3 and 2/3 is the lower lobe. You know what is it? What you do? Which lobe you examine? And then look around. Be observant. Nebulizer, medication, special food, morbidity, hospital equipment, oxygen, fluid, which fluids, any center line, child is awake or alert, they're running around or not, they seem to be ill or distressed, who is with them, you can hear any audible wheeze, cough or stridor, or if they can observe the child having some breathing difficulty by nasal flare, or subcostal intercostal recession using accessory muscle. From there, already you can have some information about your patient. You have briefly, you can have already some overview, some picture of your patient, how your patient is from there, from this only, from observation only. As usual, when talking about physical examination, started from history taking is one of it, but the other, for examination, the important is the inspection, palpation, percussion, auscultation, and then that is the turutan according when it is inside your brain, inside your brain. How is it? It have to be something that innate inside you. The face, inspection, palpation, percussion, auscultation. Inspection, palpation, percussion, auscultation. But when you examine the children, that doesn't mean you're going to follow this turutan. That doesn't mean that. It depends the opportunity, that come to you, because children's, they're not always going to be cooperative. So there is a time that you will decide that you want to auscultate first. You look at this child, you say this child is going to be a problem to do a palpation or percussion, probably not going to cooperative. Before the child start to cry, I would like to auscultate first, because if crying, usually not much information you get from the examination, auscultation. So children's, you have to be a bit opportunistic when it comes to children. When you want to examine to the children, that's why the smart come in. How smart you are to decide which examination technique that you want to go first. But basically, you have to have this standard SOP, standard step, the step inspection, palpation, percussion, auscultation in your mind. And then at any time possible, when you come to patient, especially bigger patient, you do according this step. Inspection, palpation, percussion, auscultation. But it's acceptable, the best, because you want to have the best information. You want to gather the best information from your examination in order to solve the patient problem, i.e. the diagnosis. So it's not, I mean, it's excusable if you want to proceed with other things first. But with notwithstanding, I mean, inspection will always be the first one. And doesn't matter, because inspection, you don't touch the patient, you look at the patient, you from there already you can have some idea of your patient. By inspection already, sometimes already enough. Sometimes my experience, inspection alone can help me to make my diagnosis already. So before examination, wash your hand properly, make sure, introduce yourself, good rapport, and then examination of children's, infants, examination table, preschool. If you can do on the bed, you can do on the bed, but in outpatient, we probably need to do on the mother's lap. Adolescent, mungkin sometimes adolescent Depend they want to be they are quite sensitive. They want to be treated as adult. You treat them as adult. So the very important to make a good report. Very important. The good report, I mean that good report not only with children but with the parent or caregiver, because the children notice if you are tense with the parent, usually they will reject you. So they will notice that. So more tricky. Adult, you need sometimes good rapport with the parents, with the patient only. But children, you have to have a good rapport with the children and also with the parents. Very important. If you don't have good rapport with them, they're not going to be cooperative. And they have some sense to know that the parent doesn't like you. If the parent doesn't like you, the tendency is that children won't like you also. Wash your hand properly, remember, to be clean, and then expose the area properly. And then for the younger children, it is good to have the parents the one to help to undress, because uh, children, they trust the parent do that for them. If you do it, the stranger, then they start to be regress and they don't cooperative. Look at the posture, skin color, unusual behavior. Even you have to look for parent-child interaction, fat, skinny, rashes, scars, any tenderness anywhere. And then, as usual, do general examination, respiratory. And in Malaysia, in our culture, please look at the finger first, hand first. Some people say technique wise, you can look at the head first, or you can do at the finger, at the hand first. But in Malaysia, we do hand. No matter what Mak Saleh said, because in our culture, touch head is quite sensitive. So you always get the rapport, examine the hand first in Malaysia. And then look for clubbing, peripheral cyanosis, tremor, flapping, the hand any wrist tenderness, wasting, then or you look at this first line examination, and then you look at the centrally, then at the face, you look at the the sinus, and then look at the all these clubbing, all those things. Okay, this is a clubbing, you know the clubbing. This is a type 3 clubbing, very obvious. And then the inspection, nose, throat, it is the inspection of the patient. And then when you look at the nose, patency, septum, any nasal flaring or not, nasal polyps, discharge, any sinus tenderness. The throat, look at the throat here, you can look very nice throat. The breathing airflow, the tonsils, see the tonsils, the tongue, teeth, gum, and then tonsil size. This is size big tonsil size, 3 to 4, slightly inflamed. This one, tonsils to a white pus exude from the tonsils and do infection. So you see, you look from the face, right? Face for the cyanosis and those nose and mouth. After that, inspection of the chest. So, okay, the respiration rate, you can do it when you start to touch the patient hand already. When you feel the pulse start rate, though, you can look already at the rate. And then in children, you have to realize that sometimes it's more in younger children, they tend to use the abdominal breathing. So if you have difficulty to calculate the chest, you can calculate from abdomen movement, the respiratory rate. But then they have to remind you, if you have to do respiratory rate in children, the patient has to relax. Because I can tell you, when the patient are excited, they have increased respiratory rate. You don't. Sometimes you have to put the respiratory rate during rest, respiratory rate during when they are quite excited, because they're different. That's why children will be sensitive. Even when they dislike you already, they can start their breathing can increase slightly. So look for the rate, rhythm, depth, quality. And then you look, is there any noisy breathing, any grunting, or and if you're sleeping, see any snoring. And then inspection, you know the respiratory is inspiration 1 to 2, the normal ratio. The inspiration, then expiration is 1 to 2 roughly. I mean that the this, forget about this one, just this one, the inspiration, expiration, and then there is the different respiratory rate according to the age. Remember that. And then look for the abnormal breathing patterns as tachypnea, bradypnea, dyspnea, apnea. What definition of that? Tachypnea, increase respiratory rate. Bradypnea, decrease in respiratory rate. Dyspnea, decrease in during dyspnea is distress during breathing, or apnea, which is cessation of breathing. And then the respiratory, there is rate. Kalau is a respiratory depth, hypopnea, increase in the depth, hypoventilation, decrease in depth and irregular rhythm, hyperventilation, increase in rate and depth. Firstly, usually in adult, using accessory muscle very important, especially the scalene muscle. And then in children, more of the intercostal muscle and subcostal muscle, because the neck in children, they are a bit short, so you don't see the scalene muscle very well. And then type of respiration, is it respiration pattern? But remind you, less than 6 years old, the children tend to use abdomen rather than chest. Not surprised. But more than 6 years old, by right, they are more of the abdominal than chest. When they have using a lot of chest, they're more than 6 years old. If they use more abdomen than less than 6 years old, it's a warning sign. The movement, is it the seesaw, paradox, small breathings, giant stop breathing, all these, and then seesaw is that the terbalik, the abdomen move during up during inspiration, and in the chest move down during the inspiration, and then during expiration the chest move up, then the abdomen move down. So there is a terbalik, paradox. There is in more than 6 years, it can be a danger sign. Small breathing, hyperventilation, gasping, got usually diabetic coma. And the type chain stop. Chain stop is usually brainstem injury, where the breathing is alternative, fast and then slow, and fast and slow, like that. Inspection of chest wall. That just now you mentioned the breathing pattern, then go to the inspection of chest wall. Look at the chest wall, the shape of the chest wall, the symmetry of the chest wall, any bulging of the chest wall. Look into the shoulder for any dropping of the shoulders. And trachea, also look position of the trachea. And then the chest wall, you look, very important, the chest wall is that the Harrison sulcus. Harrison sulcus is the, do we have the sulcus here? Harrison sulcus a depression, depression at the lower margin of the anterior and lateral wall, with attachment of diaphragm, which is a telling sign to you that the diaphragm is work hard and the patient have chronic respiratory distress. This is a sulcus. You Google, you come out with a sulcus. So you got a picture. Very important. A lot of children who have chronic lung problem, they will have a sulcus. Thickening of the costocondral margin in rickets, it's okay. Then inspect the posterior wall. Remember, important the wall at the posterior chest wall. Look at the curvature of the spine. The kyphosis, sclerosis. Because the spine are important. The shape of the chest is help in terms of development of the lung, and the shape of the chest also important in the mechanic of the lung. Because certain shape of the chest decrease in the size of the thorax, result in result in there is less optimum in breathing. Severe kyphosis can result condition we call restrictive lung problem. They tell you that the child, I mean, that not much lung respiratory reserve, they walk a little bit, they still get tired already. In certain severe kyphosis. Because the shape of the lung, so tell you the capacity, the shape of the chest tell you also the capacity of the lung. So the funnel chest, the patient here, pigeon chest, the patient at the lateral, and the barrel chest. There is a, a barrel there, both upper and posterior. Usually those COPD or smoker. And then generally we call pectus carinatum and pectus excavatum. Right? So examination of the trachea, look at trachea sheath, right? And then any trachea tuck or not, that's very important. Trachea tuck is that trachea pull posterior during the inspiration. You can see the trachea move posteriorly in inspiration, usually in upper airway obstruction, severe laryngomalacia or patient with severe stridor. And then try to examine the lymph nodes as in adult. So when you examine the child, start touching a palpation, always divide the lung into the upper zone, lower zone, mid zone, and lower zone. The first two rib is the upper zone, second 3 to 4 is up lower mid zone, 5 to 6 will be the lower zone. Always remember that. But notwithstanding that, there is the zone marker to help you to make your examination easy. But when you have to figure out also inside back of your mind which lobe you examine whenever you touch the chest. So this is, we do that usually started with palpation, and then okay, with palpation, of course lah, you can try all the. Okay, the palpation, the first thing is chest expansion. The important, the chest expansion is the anchor, the anchor here. This is very important. The anchor, and then when the child tarik nafas, deep inhalation to see how the movement from the thumb here, the thumb here to here, the anchor the thumb. So your hand move with when the chest move, and then the decision to say to you that good expansion is look into the how during the inspiration, how much the thumb move against each other, how far is it move. Okay, in children, very difficult to know the exact, what is the exact, like unlike adult, what 1 centimeter or 2 centimeter, 3 centimeter is not easy, So you have to have a lot of experience, and sometimes you have to the sense of to tell you that is chest expansion is normal. It's easier to done when it's adult or in bigger children, and that in that case you can use the adult size, adult. But in small children, it's not easy to do. First, the chest is small, and you have difficult to anchor, and your hand is big. So in small children, you do if you can do. If you're going to help you. Sometimes we're not that fussy. Even in our ward, we didn't do that. Because you see, in 2 years old children, you cannot expect them to understand your command. To say the tarik nafas panjang-panjang, they just don't going to obey it. So if the child's not going to obey, don't bother to do. But you have to know the technique to do it in bigger children and also in adult. So the palpation also you have to do upper, mid, and lower zone. 3 zone only. Upper, mid, and lower zone. That's all. And then you have to know the palpation. You have to know the location of apex beat. And then you have to assess the important that you have to know the apex beat is that you have to decide the mediastinum is shifting or not. There are 2 ways to know it. It's from the trachea, with the position of the trachea and the position of the apex. We tell you shifted of the, because you have to know where the normal position of the apex. You have to know apex beat, at the 4th intercostal space, at the mid line. But so you have to know that adult is 5th, but children be higher up. But then you have to know the shift. if the shift, they tell you the movement of the mediastinum, because in certain condition like pneumothorax or pneumothorax of fibrosis, the movement of the trachea and the shift of the trapeze beat tell you that they are shifting a mediastinum, and then will tell you that there's some lung pathology. Okay. Vocal fermenters. Vocal fermenters. Okay. Vocal fermenters, you use your finger, you use your hand, you use at the back of your hand, the most sensitive part, to get the vocal fermenters. Then you ask the patient to say 9999. I prefer 999 because more frequency the 1 2 3 9999 use at the back only. But that to remind you, as I say to you, in younger children, if they don't obey the command, forget it. Don't try to or struggle to do that. And then not all children will cooperate. And then when you do it, you have to know what you are doing. You have to know what you are doing. So the vocal fermenters is increase or decrease. That's all. So when it decrease, it's the condition, and this decrease is this condition. The decrease in perfusion, fibrosis, pneumothorax, emphysema, but increase in consolidation. And so there is the vocal fermenters. And then it's just upper and mid lower zone. Upper zone, mid zone, and lower zone. Vocal fermenters. And then you do percussion. Okay, percussion, very important, the technique. This is the technique. The technique is that your middle finger hit the middle finger of the right hand to left hand, middle, and in the position on 90 degrees straight like this. Very important, because the technique determine your finding. So you make a wrong technique, you won't get anything. And the movement is only at the wrist. This is the only movement, the movement at the wrist, and you hit that 90 degrees at the middle phalanx here, or middle phalanx to the middle phalanx. And you see, you have to practice this. You have to learn to percuss anything right now, so that you can differentiate the sound of cavity, the sound of solid, the sound of water. And then once you get that feel, the sound, then you can use it. If not, you're not going to able to get advantage of it, because you don't know what you percuss. And second thing, just forget to tell you that your finger here, the middle finger must be firmly pressed to the surface that you want to percuss. Firmly, not hard, firmly, and you percuss 90 degree. So practice, for practice only you get the finding. So it is the second phalanx over the go meets the second phalanx, produce the Heimer effect. Entire movement only from the wrist, not the hand, not the forearm, the wrist. The technique you have to practice. And then, okay, you have to percuss. Okay, when you percuss, you remember the sound, normal sound will be resonance, heard all over the lobes. There's a level dullness on the fifth intercostal interspace at the mid-clavicular line, and then that one is at the right side, and cardiac dullness you fell on the left side, left sternal border, on second to fourth in children. And then remember that at the end of the left side there, fifth to sixth space, there are tympanic sign due to the air-filled stomach. There is the sound, remember that. And then they're different. Liver, cardiac, tympanic, all different. Until you can feel the difference, and until then you can until you used to listen to the difference, only can you can appreciate it. That one is not, you cannot do it, you wouldn't know it until you practice. You practice on your friends, you practice on your brothers, sisters, you practice on you practice, you have to practice it. then only you can get the sense of it. And then remember, when you, okay, there's the line. Your percussion, okay, just remember the okay, when you do percussion, okay, this is how you do percussion. When you do percussion, this is where the, how is it in the chest? The you nampak ni kan, the chest kan? This how is it inside the chest. The cardiac is here, and this the liver is here, and their stomach is here. Remember that. So when you percuss, you, as usual in big children, you can you can just tap here at the clavicle first. Then they give some ideas, the resonant tu. Then initially you percuss the upper zone. Compare what left, right, left, right, left, right. Right, left, right, left, right, left. Compare first. Then you percuss every intercostal space. Until you feel here, you can feel the dullness at the fifth. And then here you can feel the dullness around here. You can feel, you percuss here, you miss the sound. You percuss a bit medial, you can feel the cardiac dullness. And here you can feel the tympanics. So this is how you percuss. The posterior the same. In posterior, when you percuss, in children, in big children or in adult, you percuss the space in between the spine and the clavicle. But in adult, in children, forget it. You just percuss straight, because difficult to find get the space. So same left and right, left and right, left and right. After that, you down, down. This is how you percuss. In the bigger children, you can do a lateral, but in small children and non-cooperative children, you don't need to do that. So this is how you do the percussion. And then remember the dullness, pneumonia, hemothorax, hydrothorax, pulmonary edema, mediastinal tumor, and the hyperresonance. We call the band block ni hyperresonant. Emphysema, cavity in lung, abscess, pneumothorax, bronchial asthma, and then you can hyperresonant. So you have to know if you think about liver position, usually at the fifth, and then remember that at 0 to 6, 1 to 2 finger breath, 6 to 24, 0 to 1 finger breath. By 2 years, you shouldn't be able to palpate it already. So that's how is it. Remember resonance. You have this normal pitch sound. You want to know, it's easy. You percuss yourself, then you feel the resonance. So what the finding? Resonance. Hyperresonance, tympanics, dull, and stony dullness. Tak payah pakai this one. Stony dullness. You use the stony dullness. Then you go to auscultation. You okay until this one?
Boleh setakat ni.
Okay, Dato.
I teaching you a bit high end, so that I want you to, when you read the book, then at least you understand the ni. I don't know, to teach you simple, to teach all bit deeper. Teach you simple kan, benda-benda things yang you tak pernah jumpa, you confused when you read. But usually kan, after I teach you all, then I'm going to demonstrate to you all with one of you become a sample nak patung buat. So I choose the smallest one. The smallest of you who going to become the behave like a patient, who going to become IE, so-called patient, that I demonstrate to you all how to do the examination. You found out we can finish the respiration within 10 minutes. But because of unluckily, because of the ni, I cannot demonstrate that to you. So many of you become theory only. Hopefully, when the things opened up, then we can use a proper education. Then I can redo back the teaching with you all. Because this thing is just theory. Medical examination is more of the practice. So you have to show that in front of you how we do the chest examination. You found out that I can talk 45 minutes to 1 hour, but when we did it, we do it in the patient, it's just 10 minutes only. So auscultation, okay, in children, first of all, when you use the stethoscope, it has to appropriate to the patient size. There are adult, pediatric, neonate stethoscope, very important. And when you in your mind also, when you auscultate, it's always the upper zone, mid zone, and lower zone. Upper zone, mid zone, and lower zone. Always think of that when you auscultate. And then you must know what your sound is. Okay, if the patient is cooperative, you can ask the patient to open the mouth a little bit and ask him to take the deep inspiration. Not very deep, right? Just a bit deeper than the normal inspiration. If the patient is cooperative, but it's not cooperative, forget it. Whatever you can do, you do. And then you must know the sound you want to do, what you want to hear. And then the first thing you must know is that what you think. The first thing you have to know is the A entry. A entry, and then adding additional sound later on. The first thing you have to know is A entry. And then, but you must know what's normal sound is this. First is that the vesicular breath sound, the bronchial vesicular breath sound, and bronchial breath sound. Breath sound. You see, this is your lung. So you see in your lung, at the anterior or the lung is mainly parenchyma here, and then there is a so this is where the bronchioles and the alveolar, and there is the trachea. So what you hear mainly around children here is the vesicular breath sound. But in small children, what happens is that this part is quite significant because the lung is small. So you hear a lot of bronchial vesicular breath sound in small children. In large children, you heard the vesicular breath sound. And then over the trachea, the main airway, you heard the bronchial breath sound. So you have to know what you listen. Very important. So for vesicular breath sound, the inspiration, the expiration ratio is there. You can see the and there's no gap. Inspiration and expiration. But in vesicular breath sound, bronchial breath sound here, what you hear is that more harsh. But this gap there, but the bronchial breath sound is a combination of this. You heard the equal, softer, but no gap. This one very nice. Very nice. You can sculpt it yourself to listen. Here you can. You want to know it's easy. You sculpt your trachea. You sculpt it somewhere near to your bronchioles, the carina there, and then you sculpt it at here at the periphery. Then you can see the different sound. That is a normal breath sound. Remember that. And then so you have to look if there's something here that will cause an abdominal breath sound. Is there fluid? If there is any solid, that will decrease air entry, or there is a obstruction to the airway, then the distal of it will be decreased air entry. So you have to recognize the sound. Then you have to understand the absent and diminished breath sound or air entry. And then so the sound, remember the entry just now. Now we go to the sound. Okay, the additional sound is satu crepitation. Kalau kat US they call rails, we call crepitation. You can find a coarse crack or fine cracks. That's why remember the wife and medium ni. Fine or coarse crack capitation. It told you that there is a air to the passage of fluid and moisture. And then the capitation. The other thing is ronchi or wheeze. If you hurt, you call it wheeze. If you hurt it at the mouth, you call it wheeze. But if you ascatate, you call it ronchi. Ronchi. And then that's the main thing, right? So when you ascatate, it's very important you recognize that. So sometimes you can see the stridor, you can hurt the stridor during auscultation, or you can hurt the wheeze during auscultation also. The stridor, the auscultation, you can hurt. The wheeze is always ronchi, when hurt you ronchi. And then that's why when you auscultate, also as usual, okay, when you auscultate, remember this how is it? You also auscultate at the upper zone, left and right, mid zone, left, right to left, lower zone, left to right, right to left. You compare between the two sound. There is a standard you compare between these two, right to left, right to left. Usually, if you're good, two breath sound is adequate. If not good, it's up to you how many you want to listen. But standard practice, two breath sound, two breathing is already adequate to tell you that the auscultation, right to left, right to left, right to left. And simply you do the same at positive sample, right to left, right left, left to right, left to right. And then if the bigger children, you auscultate the lateral side. And then from there you decide AN3, the additional sound, which is the cracks, the ronchi. The main thing, the cracks and the ronchi. That is how you do the auscultation. And then after that, you do your you examine the abdomen to look if the liver being pushed downward or not. And that one we call it as those in children. If you can get children, if the liver being pushed downward, then you can see because the position of the liver. Okay. Then if you can ask, if the children is cooperative, you can ask them to do vocal resonance. If as you say, if 999, as I say, rarely done in children, but it's cooperative, you can ask them to do vocal resonance. And then where the sound come from? Is it the sound come? You can say decrease vocal resonance, increase vocal resonance, or the sound is just near to the ears. Yeah, and then you can if it is increase in decrease in fluid diffusion, increase in consolidation, and then if very consolidate very hard, the lobar is seen to be at your ears. If you can do, and the position of the vocal resonance tell you where the pathology is. So little bit about breathing pattern. This breathing pattern, tachypnea, bradycardia, bradypnea, apnea, hypopnea, chain stop. This breathing pattern. This is the normal. This tachypnea, this bradypnea, this is the apnea, this is hypopnea, this chain stop. This chain stop when you saw the brainstem problem. This one tak payah go small. A lot go small breathing pattern. And then what is recession is, remember, the stridor, wheeze, grunting, using as a swim muscle, gasping. Gasping means that is already severe. And then, so the next thing is that, how are you going to make the conclusion of your physical finding? The example, the chest movement, percussion, auscultation. So you can look, let's say bronchitis, pneumonia, there is a decreased chest movement at that side. The percussion can be dull. If you are lucky, children can increase vocal parameters, auscultation, decrease air entry and capitation at the entry, decrease and capitation at the region where there is a during the auscultation, and at the region where the consolidation is. The asthma, reduce entry, hyperinflated, the chest movement, chest hyperinflated but reduced using accessory muscle. There is a sulcus and percussion hyperresonance, and there is a auscultation. There is a lot decreased entry and with rhonchi, use rhonchi. Cystic fibrosis, not much different from the then even there is a child can have clubbing. So very important to able to interpret the finding. In pleural effusions, the finding can be a reduced vocal tetanus, vocal frequencies, reduced chest expansion, stony dullness, reduced air entry, no air entry at all, and then reduce sometimes no added sound at all, no capitation, no rhonchi, no added sound because of water only, reduce vocal resonance. It's consolidation, increase tactile fermenters, reduce expansion, dull percussion, bronchial breathing, cause capitation, increase vocal resonance. Then you can see vocal resonance, the vocal resonance increase, and sometimes you global pneumonia, you can hear it as is near to your ears. Pneumonia, pneumothorax, trachea dilated, vocal parameters reduce, hyperresonant or percussion, reduce air entry, reduce vocal resonance. Collapse, dilated trachea, reduce status parameters, down percussion, reduce entry, and sound capitation. That's how you interpret. Mainly is a effusion, water, consolidation, pneumothorax or collapse mainly. And then the disease is this, example of the disease. Okay, any question?
Doctor,
Ah,
you want to go first? It's okay. Yeah, go ahead.
So about breathing pattern tu, kita tengok ke, kita auscultate ke, atau macam mana doktor? Kita tengok dia punya chest ke, kita tengok dia punya abdomen?
Chest lah mainly.
So maknanya contoh macam tekip ni tu, maknanya chest dia gerak laju macam tu.
Laju.
Okay, thank you doktor.
You do a respiratory rate, then you see notice higher than normal. Anything else?
Yes, doctor. You know, during auscultation, when do we use the bell and when do we use the diaphragm?
Use diaphragm only.
Oh, we use diaphragm only.
Children use diaphragm only. Settle.
Okay, okay.
Dia fikir banyak sangat pening kepala. Okay, anything else? At certain level, probably it can help you to differentiate lah. But then for your level, use one only, and it's enough already, adequate already for you. I have used diaphragm for the past 25 years, no problem. Okay, anything? Anyone else? Any other questions? It looks quite, a lot, but if I can show to you with a model, I mean, one of you become a sample for my examination, I can assure you I can finish everything less than 10 minutes, probably 5 minutes only. You don't believe me?
We believe you. We believe you.
Can do it 5 minutes, I finish already, complete. But then we see how it goes. Any other questions? Okay.
I think that's all, doctor.
That's all. So the Monday will be 12 o'clock.
Yes, 12 o'clock, inshallah.
Yeah, my teaching most of the time will be 12 o'clock.
Oh, okay.
Yeah.
All right.
Because it's the time that you all are sleepy and I also sleepy, and you are going to make your week. Okay.
Okay. Yeah. Okay. Thank you,
Okay,
doctor.
bye.
Okay. Michael.
Thank you, Doktor.
Okay.
Thank you, Doctor. Thank you, Doctor.